kudos to you for your kudos to you for keeping this event alive, and I hope the residents are taking benefit from our series. So, to coming to this important topic, that is audiology, we all know it forms the backbone of our audiology workup, especially, and the residents should be very familiar with the various basic audiology protocols and how the procedure are performed. So, and they always get a long question or one question at least from audiology. So from every point of view, it is very important. And also they get audiograms and bara in their spots also. So from every important examination, that is practical theory, it is very important. And we should be very thorough with this audiology workup. Otherwise, also in clinical practice, because of sometimes our tuning fork tests do not correlate with the audiometry, etc. So we should be very versatile and familiar with these. So with these words, I like to introduce Dr. Ravi Kapoor. Dr. Ravi Kapoor is a audiologist cum speech therapist at Government Medical College, Chandigarh, and I have been working with him for last 12 years, and he has been present in GMCH for more than 2 decades. He has a vast experience of this topic, and he has done his graduation and post-graduation from prestigious PJ Chandigarh, and he has published more than 10 articles in various journals, working in various research projects, and also has contributed chapters in the audiology books. And he is also running the cochlear implant program in our institute. And Dr. Ravi, I know, has been very active in the various academic events also. And there is, and I am very sure that he will do justice to this very, very important topic. And with these words, it's over to Dr. Ravi.
Thank you so much, Dr. Nitin Gupta sir, for kind introduction. I'm grateful to you, sir.
Excuse me, Dr. Ravi, I just want to add one point before you start. So I request all the faculty members, all the residents, if you have any doubt or any comments to make, please put it in the chat box. So Dr. Nikhil Arwar, he's our second moderator. He'll be taking up all your questions and he will be forwarding it to Dr. Ravi. So all the points will be covered. Thank you.
Good evening, everybody.
Good evening, Dr. Surendra, sir.
Good evening, sir.
Welcome.
Worthy President of AOI. Thank you, Secretary sir.
Okay, Dr. Ravi, sir, you can start now. Thank you.
Kindly allow me to share my screen. My screen visible, please.
Not now. Yes, now it is visible. Yes. Now you can start, sir.
Shall I start, please?
Yes, yes.
A very good evening to all the respected senior surgeons and all the participants. I am firstly grateful to the organizers for giving me this opportunity to share this topic of one of my very favorite topics with you on this platform. And the topic of our today's discussion is audiometry. Specifically, we'll be focusing on pure tone audiometry and subsequently impedance audiometry. So, as I understand, I'll be covering these topics, and I'm given around 1 hour time, as I understand. So I'll try to.
Sir, you can take more time, sir. No problem.
So nice. Thank you so much, sir. So to start with, we, as all of us know, that hearing is one of our 5 senses, and it is the most elusive one. It forms the foundation of language acquisition as well as speech development. So we not only detect the presence of sound with our ears, but we hear at different levels simultaneously. So In this process, we identify the sounds, differentiate between sounds, and then subsequently we attach meaning to them. So this forms the basis of the acquisition of language. Hearing also encompasses auditory memory, localization, and some temporal aspects. The most basic of the hearing assessment is the assessment of the hearing sensitivity, that is at the stage of detection, and is thus called the pure tone audiometry. So in this discussion, I'll be mainly focusing on the pure tone audiometry part, which will cover definition, applications, preparations, which includes rooms, sitting position arrangements, and the audiometer. The procedure of how to conduct the air conduction, audiometry, and bone audiometry. The variations of the procedures, then reporting of audiogram and the reliability of the audiogram, and then the interpretation, including the types of the hearing loss and the degrees of hearing loss. So, by definition, pure tone audiometry is a behavioral test used to measure hearing sensitivity. It measures the peripheral as well as the auditory systems. And the pure tone threshold is said to be the softest sound which is audible to an individual at least 50% of the times of the presentation.
I think he has left.
Must be some network issues. We contact with him.
Network issue, I think.
Am I audible?
Yes, yes.
Yeah, now you are audible. The screen is not
Sir, am I
visible,
audible?
Ravi. You are audible, Ravi. Hello.
Right, sir.
You can start sharing the screen.
Ji, sir. Of ototoxicity. To know about the efficacy of any surgical or medical intervention which has been carried out, and it also serves as the prerequisite interpretation of any further audiological procedures such as immittance or the auditory brain responses or the speech reception. Auditory brainstem responses and speech reception thresholds we'll be covering in our next session. The second application is rehabilitative, which is mainly focused in deciding upon the management options. It also serves as the prerequisite for hearing aid fitting as well as the cochlear implantation. The pure tone thresholds at 500, 1000, 2000, and 4000 hertz are used for purposes of calculation of percentage of hearing disability. Pure tone audiometry can also be used for screening those persons who are at high risk of developing hearing loss, for school-going children or those employees who work in various hazardous, noisy environments in their workplace. Coming to the equipment and the environment, which is first important thing required for carrying out a pure tone procedure. The air and bone conductivity shall be accomplished with an audiometer and transducers. Those equipment which meet specific particular specifications according to the American National Standards Institute and various Indian agencies. And these equipment need to be calibrated for proper functioning, and also be used in the acceptable test environment to assure the test results. We'll be discussing about these in further discussion. Is
There's some network connection at his end. So
I think he has left again, I think, Raman.
yes, sir. So he is there, but there is some network connection. So Dr. Ravi, there is some network issues.
Again, I think again we can ask the participant that they can send any queries on the chat, so we can collect those queries, and whenever he returns, we can keep asking them.
So any resident, if you have any kind of query, you can please put it on the chat box, and those queries can be discussed meanwhile. Any query related to pure tone audiometry or impedance audiometry.
hello.
Yes, yes. Ravi, yes, your screen is visible.
Right. Thank you so much. Can you please give me some idea as to how much could I be listened when what was the last slide when I was off?
Calibration of
Right. Thank you, sir. Thank you, sir. So that means only just one slide next. Is this picture of audiometer visible?
Yes, yes, it is visible, sir.
So one important thing which we should always observe while carrying out any pure tone audiometry procedure is that we should familiarize ourselves with our equipment, and the basic design or structure of the panel of all the audiometers is more or less similar. It has got one dial or maybe some buttons for changing the intensity. Another one will be for changing the frequency, and the third important button is the signal presentation switch. So these are the three basic buttons which are always available on the display of panel of the all the audiometers. So here we can see another display of the panel of an audiometer. In this display, the frequency of the pure tone in kilohertz is displayed here, then intensity in decibels, then the masking level, then it shows the whether it is air conduction, bone conduction, right or left, and is my pointer visible?
Yes, yes, sir. It is visible.
This area here we can see whenever the patient gives the signal that he or she has heard the tone, he or she when presses the button, an indication is shown at this point. Then we can see this is the frequency changing panel. This button is for lowering down the frequency. This button is for increasing the frequency. Then we have intensity control. So with this button, we can reduce the intensity, and this button helps us in increasing the intensity. This is the interrupter switch, which is again very important. Whenever we press this, that the signal, that is the pure tone of the particular frequency and intensity, is presented to the transducer of whichever specification we have opted for. So these are the various transducers which we can select. This is a supra-aural earphone, which includes the ear cushions and adjustable headband. It can be adjusted according to the size of the person's head. This is the insert earphones along with soft sponge ear tips, which are disposable and can be changed for every case. And this is a bone vibrator along with a headband. So appropriate transducers need to be selected and then used for conducting uh, the procedure. Now we come to the test environment. This is one of the most important aspects of getting reliable results from the procedure of pure tone audiometry. So the various agencies have given specifications worldwide for maximum permissible ambient noise levels for audiometric test rooms. So the use of sound booth or isolated sound rooms is viewed as a standard practice, and it has to be taken care that there should be proper control of temperature, air exchange and humidity inside the room. This is to maintain the recommended temperature range for operation of the audiometer. And proper ventilation is also required for comfortable concentration, focusing and attention of the person whose hearing is being checked. Then warning systems for fire as well as civil defense need to be incorporated inside the rooms. And in case of some emergency conditions, telephone or panic buttons should be displayed very prominently inside the room so that the proper alarm at proper timing may be initiated. So in order to avoid some distractions during the conduction of the process of audiometry, uh, it may be taken care that various mobile phones, pagers, radios, and other communication devices should be either turned off or silenced during the audiometric evaluation. Is the picture of a typical audiometry room visible on this slide, please?
Yes, yes. Yes, sir, it is visible.
So we have on the left side, thank you. We have a audiometer, a typical audiometer, computer-based audiometer on the left side. And on the right side, we can see the person being comfortably seated on a chair, and the earphones are being placed after giving appropriate instructions. This is a typical audiometric booth in which the person is seated comfortably, given instructions, and the transducers are placed. Then the door is closed, and we can see that there is a see-through window through which the response of the person can be observed, and the audiometer which is placed outside the window can be operated upon. Also, the standard uh, protocols and procedures for infection control must be carried out whenever uh, one instrument has to be used for multiple persons. So before initiating the pure tone audiometry procedure, the visual inspection of the pinna and the ear canal, including the otoscopy, should be carried out. And this is to rule out any active pathological condition such as discharging ear or the pus collection in the external ear canal, which should be cleaned. And secondly, if there is excessive cerumen in the ear canal, that has to be removed before carrying out the audiometry procedure. The participant should be seated in a safe and comfortable manner, and the instructions should be given in such a way that the language should be comprehensible and the manner should be appropriate for the participant, as we know that the participant could be a child, an adult, or a geriatric person. So the factors that influence the results of pure tone thresholds include the instructions to the participant, response task by the participant, and the interpretation of the participant's response behavior during the test by the clinician. So the placement of transducers include, for air conduction, we usually use earphones, the supraoral earphones. And for bone conduction, we use a BC or bone conduction vibrator, which is placed at the mastoid. For determination of threshold, we incorporate various techniques. Initially, historically, the ascending technique was used, where the sound which was of inaudible intensity was raised till a response is generated. And this is the ascending technique. Another technique was descending technique, wherein a very loud intensity sound is introduced and then it is decreased till the response fades. But then later on, during the developmental phase, they incorporated both the techniques, in which they increased, they used the ascending method and the descending method in order to bracket the threshold of the tone. The tone which is used is presented generally for about 1 or 2 seconds in duration, and the interval between the successive tones is varied but is never shorter than the test tone itself. So the first presentation can usually either be below the expected threshold or above the expected threshold. And the levels of succeeding presentations, uh, they change in such a manner that if the intensity is increased, it is increased in 5 dB steps. If the intensity is decreased, it is decreased in 10 dB steps. So 5 up and 10 down. That is the technique to be followed while carrying out a threshold estimation of for pure tones, whether it is bone conduction or air conduction. So the level of intensity or dB at which if we present the tones for 3 times or 4 times, maybe 6 times, half of the times, at least half of the times, the response should be present. So that is marked as a threshold of that particular pure tone. So the variability of threshold measures is to be assessed by the clinician, and acceptable test-retest variability for a given participant should always be mentioned on the audiogram. So if we are a beginner, we should follow the fixed testing procedure, and until we gain a sufficient experience, we should not usually vary from the fixed standard laid down procedures. And the first step in acquiring a pure tone audiogram is to ensure that an audiometer has been connected to the power supply and is switched on. Is the video
Yes, it is visible.
playing?
Yes,
Thank you.
video is playing.
So here, this is important that we switch on the audiometer. The AC mains are on and the audiometer is switched on. This is one of the first and foremost step, but very important steps. Then we need to connect the various uh, transducers in their respective jacks correctly. The international code goes that red is to be used for right and blue for left. So we can see this red dot and blue dot, red for right, blue for left. Usually the BC vibrator is shown in black only. It should be ensured that the earphones may be placed directly over the external ear canal, and the height of the earphones may be adjusted with the help of the adjustable band, and there should be no hair in between the earphone and the ear. So starting with the first frequency, usually it is selected 1000 hertz, and the tone is presented in preferably the better ear. 1000 hertz is the middle frequency and the most sensitive area in the hearing spectrum. And it is also a clear tone to hear for a person who has never had a hearing test before. The initial intensity of presentation is around 30 decibels. And if the response is there, then it is reduced. If it is not there, then it is increased. So once the response is observed, the intensity is lowered in 5 dB steps. And if it is, it is lowered in 10 dB steps. If it is not observed, then it is increased in 10 dB steps. And the level at which at least 50% of the times of presentations, the response is there, is marked as the threshold. And here in this, we can see that the intensity at 30 decibels for 1000 hertz, no response was observed. No, sorry, response was observed, so it was reduced by 10 decibels. Again, response was there once, twice, then it was reduced again to 10 decibels. No response could be observed. Increased by 5 dB, 15 decibels, no response once. Second time response was there, third time response was not there. So increased by 5 decibels, again at 20 decibels, first time no response, second time response, third time again response. So we will mark this 20 decibels as the threshold of hearing at 1000 hertz on the audiogram. Similarly, we will change the frequency. We'll test the other frequencies such as the octave frequencies 2000 hertz, 4000 hertz, 8000 hertz, and then we come to 500 hertz and 250 hertz. So if there is a difference of more than 20 decibels between two consecutive octave frequencies, for example, 20 decibels at 1000 and 40 decibels or more at 2000 hertz or 5000 hertz whatsoever, then we check the intermediate frequencies at 750, 1500, 3000 and 6000 hertz. And whatever the threshold is obtained, we simultaneously plot it on an audiogram. So the order goes as 1000, 2000, 3000, after 2000 it goes to 4000, 8000, and then back again to 1000 hertz, then 500 and 250. So retest at 1000 is considered as a control. If there is a variation of less than 5 decibels, then it is assumed as satisfactory accuracy. But if it is more than 10 decibels, then the reliability is questionable, and the procedure is again repeated from the initial steps. So this completes the observation of obtaining of pure tone thresholds at 6 octave frequencies 250, 500, 1000, 2000, 4000 and 8000 hertz in 1 year. And then if it was preferably a better year, and then it is repeated the same, all the steps are repeated for the other year. If this was the better year, it would be then the poorer year. So at each frequency, when we are repeating the procedure for the poorer year, it should be observed that if there is any need for masking or not. So we are conducting right at the moment the air conduction pure tone audiometry procedure. So when, why, and how to mask, we will discuss now. As we can see that whenever we present the tone in one ear through the air conduction mode to test one ear, if it is a loud sound, the sound attenuates and goes to the, it stimulates the other cochlea. And this attenuation, called the interaural attenuation, is around 40 decibels for air conduction. So if we present an 80 dB sound in one ear and suppose the threshold is 20 decibels in the other ear, 80 minus 40 is 40 decibels, will be heard in the other ear. So there is a need of providing masking in the other ear. Similarly, if we place a BC vibrator on the skull bone mastoid process specifically, it stimulates through the whole skull both the cochleae simultaneously. So the interaural attenuation is said to be 0 decibels for bone conduction. So whenever we are carrying out a bone conduction audiometry, we should always perform the masking in the non-test ear. So wherever we are presenting the signal, we consider it as the test ear, and the other ear is considered to be the non-test ear. So the masking is the sound or signal which is presented to the other ear, which is not being tested from, it precludes the non-test ear from participating in the test process. And it is also used to avoid the crossover signal from being heard. So it is, the crossover may also be called the contralateral lateralization of signal. So the various concepts which are important to remember while performing a masking procedure are the test ear, in which we are actually observing the thresholds. The non-test ear is the opposite ear, which we don't want to participate. And then the interaural attenuation, which is the energy lost as the sound travels from one ear to other. The minimum levels of interaural attenuation guide the tester as to when the crossover is likely to occur. The various values for air and bone conduction are different, whereas it is 0 for bone conduction, it is around 40 for air conduction. It also varies with the use of different transducers. For supraaural earphones, it is 40 decibels. If we use insert earphones, then it is more, say, in the range of 50 to 70 decibels. This is the main advantage of using insert earphones. And as we discussed, it is 0 for the BC vibrator. The minimum effective masking is the minimum level of narrowband noise, the NBN, or the noise which is centered at the test frequency. It is used to prevent crossover. And the safest level to start masking is the air conduction threshold of the non-test ear plus 5 decibels. So when to mask during AC air conduction audiometry? Whenever there is a difference of more than or equal to 40 decibels between the test ear and the non-test ear, so we have to insert the masking in the non-test ear. Similarly, how much masking? The AC threshold of the non-test ear plus 5 decibels. In case of BC audiometry, when to mask? If there is an air-bone gap of more than 10 decibels, we surely have to mask. How much masking? AC of the non-test ear plus 5 decibels. So this is the safest minimum level. Then another consideration which we should take care is the occlusion effect. As we know that during the Bing test, when we place a vibrating tuning fork on the mastoid process and we alternatively close and open the ear canal by pressing the tragus, there is an increase in the loudness perceived. So this is mainly because of the occlusion effect, which takes place at the lower frequencies. So in order to compensate for that, the formula goes that we have to add at 250, 500, and 1000 hertz, 20 decibels, 15 decibels, and 5 decibels respectively. So the formula becomes AC of the non-test ear plus 5 dB plus occlusion effect, and that is only for BC masking. So the instructions which need to be given very clearly to the person, that he or she will be perceiving tone in one ear and noise in the other ear, and the noise should be ignored, and only the response in form of pressing the button should be given for the whistle tone or the beep beep sound. So as we discussed, either narrowband noise, and traditionally the provision of giving white noise also, or which is a wideband noise, has also been mentioned in the books. But for the last 25 years, I have seldom used white noise. I have mainly focused for pure tone audiometry, air conduction, bone conduction, narrowband noise of that particular uh, frequency have been used. So the purpose of doing bone conduction audiometry is to determine if there is an abnormal air conduction test. There is a difference between the air conduction threshold and the bone conduction thresholds. So this helps us in determining whether it is due to conductive mechanism pathology, or the middle ear pathology, or the sensory neural, that is inner ear, or the auditory nerve pathology. So the normal bone conduction with abnormal air conduction indicates a middle ear pathology, while when the hearing threshold at uh, both air conduction and bone conduction are more or less equal, then it is likely to be a sensory neural pathology. So bone conduction audiometry is done with the help of an electromagnetic vibrator or a bone conductor, which is placed on the mastoid behind the ear and is held in place with the headband. And it has to be pointed out to the participant or the patient that he or she may hear the tone in the ear which is not being tested, and that should be reported, so that masking, which usually eliminates this problem, can be incorporated. The step-by-step procedure for bone conduction audiometry is similar to air conduction. So preferably the better ear is tested first. And to determine this, we perform an audiometric Weber test, where we place the bone vibrator on the forehead, and the person and the tone is presented. The person is asked to lateralize the tone in whichever ear it is being heard. And usually the frequency of presentation is 250, 500, 1000, 2000, and 4000 hertz. And the intensity of presentation is around above 20 dB above the air conduction, the best air conduction threshold. So if it is lateralized in the midline, it means that both the uh, thresholds of the both the ears are more or less similar. So this is specifically the placement of the bone vibrator, and it has to be ensured that no hair are precluding the vibrations from the bone vibrator to the skull. Starting at again 1000 hertz, 10 dB above the air conduction threshold, and 5 plus 10 down method. And theoretically, always we need to mask in case of bone conduction, but practically, if the air bone gap is more than 10 decibels, we definitely need to mask. Now, for placement of the masking earphones, it needs to be taken care that if the bone vibrator is on the left side of left mastoid, then the right earphone has to be placed on the right ear itself, but the left earphone will not be covering the left ear so as to avoid the occlusion effect, and it is placed somewhere at the cheek of the person so that it is comfortable also. So all the frequencies starting from 1000 going through 2000, 4000, and then 500 and 250 hertz. Again, retesting after 4000 at 1000 hertz. Recheck is again very helpful. And the appropriate symbols on the audiogram key we'll be seeing in future slides will be marked for whether unmasked bone conduction or masked bone conduction. Similarly, masked air conduction or unmasked air conduction, we'll see in our future slides. So in order to avoid some errors while conducting the air conduction and bone conduction, there are some pitfalls which we always need to take care so as to give an authentic hearing thresholds in for air conduction as well as bone conduction. So first is that tones should never be presented in a prolonged manner. They should be in short bursts, say for 1 to 2 seconds, average 1.5 seconds. Then the audiogram should be done quickly as possible, but not hurriedly so as to compromise the accuracy of the procedure. We should allow sufficient time to the patients, depending upon their age, for giving appropriate responses. We should always make sure that we do not give any visual clues directly or indirectly uh, while operating the audiometer. Uh, for example, if we press the interrupter tone and then look at the person, so the person expects that we are expecting a response from him or her, inadvertently, whether the sound is heard or not, presses the button. So this we need to always be careful. We should place the right earphone, the red right earphone on the right ear, the blue left earphone on the left ear, and place the BC vibrator on the respective mastoid processes. Recheck at 1000 hertz is always a helpful practice. Uh, we need to give some frequent checks on our own self. We can place the earphones or on our own ears and then present the tones to right and left ears at soft intensities to check whether we are handling the uh, correctly working audiometer. Then there becomes sometimes monotony in the procedure. After every, say, 2 or 3 seconds, we keep giving the tone, so that rhythmicity, the person who is not having that hearing sensation may sometimes be able to sense. So that has to be avoided. In cases where the person is having tinnitus in the ears, so a pure tone, specifically a monotone, may be changed in such a manner that a warble tone, which is a plus minus 5% of the frequency, a wobbling tone, a wobble is there. So that is also equivalent to a pure tone, can be given so that the person does not get confused between his or her own tinnitus and the tone which is being presented. Do not press the tone presenter switch down too hard or let it spring back too quickly, because that might cause some clicking sounds. So that may be again misleading and causing false responses. The other special tests which include the pure tones include we'll be discussing in our next session, the recruitment test and tone decay. These also utilize pure tones. Uh, then some adaptation of audiometric techniques for special populations, such as those, for example, firstly, the non-organic hearing loss, or also called, we call it as pseudo-hypoacusis. It could be either psychogenic hysterical deafness, either, or malingering, which is deliberate falsification of the hearing loss. So wherever there is some financial compensations, the organicity may be a suspicion. Then if the person is exaggerating the posture, um, or relying overly on lip reading, so may evoke some suspicion of non-organicity. Then in cases of geriatric cases, we should be handling the person with the due dignity and give him or her the adequate time to respond, as the elderly may be having some motor difficulties or some stiffness in their hands due to some comorbidities, or maybe uh, because of their natural aging process. Uh, in cases of there is again another population, the pediatric population, where the variations could be of behavior observation, visual reinforcement, or play audiometry. So we need to train the child or condition the child for responding whenever there is a sound. And firstly, without placement of any transducers on the head, with the use of some noisemakers. And then later on, introducing very gently the transducers to the child, and then making him or her respond to the pure tones. So this helps in generating very reliable pure tone audiogram on in cases of children as young as 3 to 4 years. Another variation is the use of sound field audiometry, wherein if the child or any person, the elderly, if the ear canals are pressing, and the collapsed canal may occur. So in those cases, we can use sound field audiometry, where the loudspeaker is used to present the uh, tones. But the main disadvantage is that it is not ear specific. So coming to the reporting of the audiogram, the x-axis shows the frequency in hertz, and y-axis shows the intensity in decibels. Various types of audiograms, right? We can plot both right and left responses on the same audiogram, or
Hello, Dr. Ravi. Dr. Ravi, so your voice is breaking. Hello. Dr. Ravi, your voice is breaking.
Your pitch is there more.
So I can see Dr. J.C. Pasi sir has also joined. Welcome, sir. Good evening.
Good evening, sir. Good evening.
So you need to unmute yourself.
Hello, am I audible now?
Yes, sir.
Yes, Dr. Ravi is doing a very fine job. Where has he disappeared?
There was some network issues at his end. So
Okay.
he's trying to
So,
connect.
how many people are listening to the program right now?
There are 56 participants. of now.
56.
Yes.
Okay. And residents out of these, do we know?
No, we can't. We can't appreciate.
Okay, okay. So our main concern is whether the actual audience is there or not.
Attendance is better before.
Is better now?
We
Attendance is better than before?
will- I
Yes,
think last lecture Zoom meeting attendance was very low.
Yes, it's better than the previous one.
Yes, sir.
Okay. So this is a very, very important topic for all the postgraduate students and the senior resident. For PGs, it is very, very essential in their practical life, and also for theory point of view. And it is always a part of the question paper in theory in some form or the other. So instead of mugging up this slightly difficult area of audiology, if they structure the topic like Dr. Ravi has done and he is delivering, so things will become easier and the concept will come in. I think he is now joining us back.
yes. Dr. Ravi, you just need to click on the link I have provided to you. Okay, now your screen is visible. Yes.
Oh,
Yes.
thank you. Am I audible?
Yes, you're audible.
Yes, yes.
Thank you. Can you please tell me, was this audiogram key visible?
Yes.
Till the connection was off.
Yes.
Audiogram key was.
You were showing us the different types of audiogram graphs.
Audiograms,
And
right.
the right or the left, and some people are drawing on these same graphs. Yes.
Right. Thank you.
Yes, sir.
So this is the audiogram key, which has to be incorporated on the audiogram itself, which helps us in plotting the correct thresholds, and again it helps in the interpretation of the results. So this is a typical layout of an audiogram, and here uh, above the demographics we can place the name of our institute, and various other logos can be placed, so that whosoever sees the audiogram knows that where this procedure has been carried out. Then we can interpret the various types of audiograms. The WHO suggests the various degrees of hearing losses, ranging from normal, mild, moderate, severe, and profound. The shape of the audiogram helps us in determining the type and again the degree. The conductive type of hearing loss is usually a flat or more pronounced at low frequencies, whereas the high frequency sloping type of audiogram is usually a sensory neural hearing type hearing loss. Then in cases of age related changes, the presbycusis, high frequency roll off or the increase in thresholds at higher frequencies is observed. Noise induced hearing loss, the characteristic is a sensory neural notch at 4000 hertz, and the other contours may indicate various others pathologies. So here we can see that the left ear, the blue crosses are within the normal limits. The red circles show the air conduction thresholds at 500, 250, 500, 1000, 2000, 4000, and 8000 hertz. And the red brackets connected with the dotted lines, these are the bone conduction thresholds, masked bone conduction thresholds of the right ear. And since there is a gap of more than 10 decibels in the air conduction and bone conduction thresholds of the right ear, this indicates a conductive type of hearing loss. the average being around 30 decibels air conduction and around 5 decibels, 3 to 5 decibels in bone conduction on an average. Similarly, here we can see a high frequency sloping type of loss. The air conduction and the bone conduction thresholds are same. So there is no air bone gap. So this indicates a sensorineural type of hearing loss. In this audiogram, we can see uh, there is an airborne gap, the conductive loss is there, and there is a dip at 2000 hertz in the bone conduction audiogram. So this is typically indicative of the seen in the cases of otosclerosis. This is called, or this is popularly known as the Carhart notch. This is the typical high frequency, 4000 hertz sensory neural dip, the Boilermaker's notch, indicative of noise induced hearing impairment. This audiogram shows right ear normal hearing, whereas the left ear is having sensorineural hearing loss, and it is more pronounced at the lower frequencies. So unilateral hearing loss may be indicative of Meniere's disease. In cases of sudden sensorineural hearing loss, we perform serial audiograms. Here we have left ear normal, right ear is having severe sensorineural hearing loss. And if we see, this is the first audiogram, the second one is the better, third medical intervention. So if you allow me, shall I run this sudden sensorineural hearing loss serial audiogram once again, please?
You can
Am
do,
I
Ravi.
audible?
You can do.
Please, thank you so much. So this is the first serial audiograms showing right ear severe hearing loss of 80 decibels, then it improves to around 75 decibels, then it further improves to around 35 to 40 decibels. The inconsistencies which might be observed during the audiometric techniques originating from the clinician or the client and or the equipment. So usually we see if the bone conduction thresholds are lower than a inconsistent audiometric pitfall. Then if the retest consistency is not observed, then it is again should be mentioned. If the interview test discrepancy is there, talking loudly but presenting a relatively normal hearing, we should again look at our own instruments first. So coming to the next topic of impedance audiometry.
Dr.
It
Ravi,
is basically, sorry,
Dr. Nikhil,
please.
this side actually, just before moving, I think we can take one or two queries regarding Proton audiometry.
Yes, sure, please.
Yeah, so there is one question that they're asking, if you can explain them, what is the difference between white noise and the narrowband noise? Which one you prefer and why?
Okay, great. So, you see, I would like to mention here that the white noise is also known as wide band noise, and this type of sound or noise, it comprises of most of the frequencies available in the audible range. So for example, if we are testing 250 to 8000 hertz, all the frequencies will be present in the wideband noise in case of a wideband noise. But in case of a narrow band noise, if we are testing 1000 hertz, the 1000 hertz frequency will be placed at the center. It will be the central frequencies. It will be the center frequency. And say, for example, 100 hertz plus and 100 hertz minus that central frequency will constitute a narrow band of that particular central frequency. That noise will be introduced for masking purposes while testing 1000 hertz. If we change it to 2000 hertz, then the central frequency will be 2000 hertz plus, say for example, 200 hertz plus and minus 200 hertz will constitute a narrow band of 2000 hertz, and that band will be used as the masking noise for 2000 hertz. Similarly, for 4000, 8000, 500, and 250 hertz. So, since this narrow band noise is specific, frequency specific, that we prefer narrow band noise as compared to white noise. But in cases where we in the audiometer itself they have not incorporated the facility of narrow band noise, then we at least have white noise or white band noise for at least for the sake of masking. So definitely narrow band noise is preferable. I hope this answers the query.
Yeah, great. So I think the second query regarding behavioral and visual reinforce you have already covered. Just one point addition from my side in the uses of pure tone audiometry. It's a very important medical legal document also. So that's also a very important use. And one query which I was expecting, but what in your practical experience, what is the role of high frequency audiometry? What is its use for and how frequently you use it?
Right. So again, very important question. You see, it has been observed in the various reported in various studies that before the commencement of hearing loss at the standard frequencies between 250 to 8000 hertz, the loss starts showing itself, the hearing loss starts showing itself at higher frequencies, which include 12,000 hertz, 14,000 hertz, 16,000 hertz, 18,000 hertz, 20,000 hertz. So there have been various normative data which have been collected for the intensity or the threshold at which 18 to 25 years old young adults they respond to high frequencies. So the application is again while monitoring the ototoxicity, the effects of medicine on the hearing, the high frequency audiometry is very helpful. And similarly, in cases of age-related changes, if we want to see the occupational hazards, early changes in the ear. But the main difficulty of conducting this is that the audiometer has to be an advanced one, which has the facility of producing the high frequency pure tones. The earphones, the transducers are different as compared to the standard audiometry. They no doubt are the supraaural ones, but the frequency response, the electro technical characteristics are different as compared to the standard audiometry transducers. Probably this answers the query.
Yeah, okay. I think now we can move forward and we can take some of the queries later on. So
Correct.
impedance audiometry, I think we can start with now.
Thank you so much. Proceeding with impedance audiometry, we observe that it is an objective method and no patient participation is as such required. And this is mainly done to measure the pressure in the middle ear, to check the stapedius reflex and the tension of the tympanic membrane. And it is one of the most common and most accurate methods for testing the middle ear. So it is used to determine the status of the tympanic membrane, middle ear via tympanometry, as well as the acoustic reflexometry. So two bifurcations of impedance audiometry, tympanometry and acoustic reflexometry. So there are various terms which are used in the impedance audiometry heading. These include emittance, admittance, impedance. So there are some differences, some small difference, subtle differences, but important ones, which we shall see now. The impedance measures the middle ear system It measures the opposition of the flow of acoustic energy. It is depicted as denoted as Z and measured in acoustic ohms. On the contrary, the admittance measures the ease of flow of acoustic energy in the middle ear system. It is denoted as Y and measured as acoustic millimhos, MOHOS, the reverse of ohms. So as it is the reverse of impedance. Admittance is reverse of impedance. So admittance has got three components. The first one is the mass susceptance. The second is the stiffness susceptance, and the third one is the G. Currently available instruments, they measure admittance. So in tympanometry, we measure the acoustic emittance in the external auditory meatus as a function of air pressure within the external auditory meatus. The tympanogram indicates how the emittance of the ear is altered when the ear canal pressure varies. So the acoustic admittance peak is composed of two major points. Firstly, the admittance of ear canal, and the admittance of, secondly, the admittance of the middle ear on the lateral side of the tympanic membrane. The conventional emittance evaluation of middle ear functioning is done at 220 Hertz probe tone, and it is an effective measure of middle ear function in adults as well as children. So various types of tympanograms can be observed during the tympanometry. If we see this probe of an impedance audiometry, we can see how this is inserted. This is the probe having a probe tip, a soft probe tip, along with the uh, various sizes of this soft probe tips are available, so that it can fit the different sizes of various different the clients. Then these tympanograms which are observed on the screen can be classified on the basis of Jerger's classification. For example, in this particular tympanogram picture, we can see that it is a type A tympanogram. Two parameters are usually observed. One is the compliance, that is the height of the tympanogram, the peak at which the maximum compliance is observed. And the second one is the middle ear pressure in decapascals. So here we can see the compliance is 0.46 and the pressure is minus 16. So we term it as a type A tympanogram. Similarly, in this one, though the pressure is normal, but the compliance is reduced. So it is a shallow type of tympanogram. The S stands for shallow. Conversely, when the compliance goes beyond this range, more than 1.5, then it is termed as type AD. D stands for deep. A flattish type of tympanogram indicating fluid in the middle ear, no change in the admittance, is termed as type B tympanogram. In case of type C tympanogram, the maximum admittance compliance peak is shifted towards the negative pressure. Here we can see minus 125 middle ear pressure. Similarly, in this case also minus 108. The reflex arc is important while conducting the reflexometry. We should be aware that the sound travels from external ear, middle ear, inner ear, eighth nerve, eighth nerve, cochlear nucleus, superior olivary complex, and then from the facial nerve nucleus, it gives the neurons to the stapedius muscle. It contracts upon receiving reception of loud sounds. So the acoustic reflex threshold and acoustic reflex decay are the two things, the tests which help us in identifying the behavior of the stapedius muscle. So here we can see a tympanogram has run, and then it switches over to the reflex measurements at 500 hertz. 500 hertz, it changes the frequency from 80 decibels to 85 decibels, then 85 decibels to 90 decibels. It can show, it can observe a significant change in the compliance. So it gives, it further stops and gives a value of 90 decibels at 500 hertz acoustic reflex threshold. At 1000 hertz, it gives 85 decibels as the reflex threshold, and 2000 hertz, 90 decibels. Similarly, in the other one, we can see that the tone is given continuously for 10 seconds. The contraction of the stapedius muscle has to be sustained for all the time in case of a normal, this one, a normal ear. But if it reduces by 50% in first 5 seconds only, but it may be indicative of retrocochlear pathology. The clinical applications of impedance audiometry include pathological identification of pathological conditions of the middle ear, to check whether the patency of grommet which has been inserted is there or not, and also to check the eustachian tube function or dysfunction whatsoever. Then variation in the probe tone from 226 hertz, which has been observed to be less effective or less sensitive in cases of the children who are less than 7 months of age, has led to the development of high frequency probe tone of 678 hertz or 1000 hertz. So this is because the young infant's middle ear is more mass dominated rather than stiffness dominated. And low frequency probe tones are most sensitive to the stiffness dominated systems. So this is why in various countries they have taken included this high frequency tympanometry as a part of their screening protocol for hearing impairment. Usually 1000 hertz probe tone has been observed to be showing more promising results. So these have been incorporated for neonates. In case where in small children autocaustic emissions are absent, tympanogram with 226 hertz is normal, but still conductive components are prevailing. So for these, if 1000 hertz probe tone is used, then it is utilized to measure the admittance tympanograms, such as in this particular slide, we can see 1000 hertz probe tone is yielding a specific type of tympanogram. This is just a indicative video. Then further going into another advancement of tympanometry, multi-frequency tympanometry is used, where the various components of admittance is used to see the change as a function of probe frequency. The probe tone frequency is changed from say, for example, 226 hertz to 2000 hertz to obtain various different tympanograms, and the frequencies at which these changes occur, these are different for normal cases than pathological cases. Now, one such frequency is the resonance frequency of the middle ear. The changes in the transmission characteristics of the system can be easily determined from the changes in the resonance frequency. So the multi-frequency tympanometry provides a more accurate and detailed information about the middle ear dynamics as compared to the standard tympanometry using low frequency probe tones. Specifically, the conditions of autosclerosis and rheumatoid arthritis characteristically increase the resonance frequency of the middle ear, whereas the conditions such as ossicular chain discontinuity, atelectatic tympanic membrane, and otitis media with effusion typically decrease the resonance frequency of the middle ear. So it can also assess the stages of rheumatoid arthritis in presence of middle ear involvement. The resonance frequency can be affected by mechanical impedance of the cochlea, and thus multi-frequency tympanometry can be helpful in diagnostic workup of the large vestibular aqueduct syndrome. These are the references. Thank you so much for your kind listening. If there are any more queries, please.
Hello, Dr. Nikhil.
I think we covered the query. Just one query was left. In the BPPV patients, are you routinely doing Puritan audiometry, and any particular role you think in BPPV patient or PTA?
Yes, right. So, as per our departmental protocol, we whenever the person complains of any uh, dizziness or disequilibrium, firstly we get a pure tone audiogram done, and then we if there is a requirement for middle ear assessment, also impedance audiometry. Otherwise, then we get a vestibular evaluation done, which includes majority of the investigations such as the VNG, the SVV, apart from others, and this is to rule out either whether it is BPPV or any other etiological cause which may be contributing to the disequilibrium. Probably this answers the query.
Okay, I think there are no more queries,
I
Raman.
think there is one more query. How to do masking
Yeah.
in a case of unilateral hearing loss? There was one query in the chat box.
Okay. So while so the procedure the standard procedure goes wherein we firstly we obtain the air conduction thresholds. So in case we suppose that it is a unilateral hearing loss, so either one side will be normal or having mild hearing loss, and the other side will be having a more severe hearing loss as compared to the better ear. So it could range from anything from mild, moderate, severe to profound. So the specific query of masking is in case of air conduction. Firstly, air conduction audiometry, we will, as we have discussed in the procedure, the air conduction thresholds of both the ears will be taken firstly. So now, if there is a difference of more than 40 decibels between the two ears, then we will introduce the masking noise in the better ear, and then we will test for the masked thresholds in the poorer ear. The formula, as we have discussed, the AC plus 5 dB plus the occlusion effect. We'll start with that, and then we observe 3 consecutive presentations, and the threshold will be obtained for one frequency. It will be repeated for other frequencies, starting from 1000 to 2000, 4000, 8000 hertz, coming back retest at 1000 hertz, 500 and 250 hertz. So this will give us the masked or the true thresholds of the poorer ear. So this will be in case of air conduction. And then similarly, we will introduce noise in the better ear to obtain the bone conduction thresholds of the poorer ear. So that will be 1000, 2000, 4000 hertz, and then 500 and 250 hertz. So this will help us in yielding true thresholds of air conduction, bone conduction in the poorer ear, as well as we can repeat the bone conduction testing for the better ear also. If it is normal in within the normal range, we need not provide any masking noise. Hopefully this answers the query.
Yes, yes.
Yeah.
Thank you. Thank you, sir. So we have 5 minutes left and we can take one more query.
So one question which I think
Yes,
I can ask from my side is from Ravi is that when we get an audiometry of a patient and we are not satisfied with the result, especially this happens when some medical legal issues or so the patient seeking admission for the MBBS etc. Then how much duration should be kept between the next audiometry for this candidate, and why is this duration important to keep?
Sir, very practical and important points are which you have brought forth before the house. And according to my observations and going through various texts, the basic idea is that here we are suspecting some non-organicity in the hearing loss. It may be there, it may not be there. It may be exaggerated responses, and the basic purpose is to obtain some benefit. It may be financial or otherwise. Now, the basic idea goes that if, say, for example, a person has uh, one actual threshold and the second is the committed threshold. So if it is an exaggerated committed threshold, the auditory memory for that has to go off before the second test can be applied. So whenever a person is wearing the earphone and the intensity and the frequency is being tracked as low as possible. So one is the true threshold, the other is the committed threshold. If it is exaggerated, then it has to be above, say, 10, 20, 40, 50 above the true threshold, the committed threshold. So the auditory memory has to go off before the second can be. So at least 7 to 10 days has been documented before we can go for another second one. If we keep on administering the procedure repeatedly, very frequently, then that auditory yardstick which has been fixed as committed threshold will be coming again and again. So we'll not be able to track down the true threshold.
Thank you.
Probably this
Thanks a
answers
lot.
the question. Thank
Yeah,
you,
yeah.
sir. Thank you, sir.
Raman, you unmute yourself.
Pardon, sir. Sorry.
Raman,
So, right, sir. So if any participant has any other query because of the time constraints, I have posted sir's mail ID. So you can post your queries on the mail ID and sir will answer. And now I would like to invite our senior faculties who have joined today, Dr. J.C. Pasi sir, Dr. Aditya Bhargav sir, to please say a few words. And then we can conclude the session.
Dr. Pasi,
Dr. Pasi, please, sir, unmute yourself. Dr. Pasi, sir, please unmute yourself.
Am I audible now?
Yes, yes.
Yeah.
I could join late. Actually, I started from my office very late.
Good
So,
evening.
and I heard most of the lecture on my way back to home. I really congratulate Dr. Ravi Kapoor and the department where he is working for an excellent presentation of both theoretical and practical aspects has been covered very nicely. As I said, that this topic is very, very important for all the postgraduate students for making concepts about audiometry and also preparing the topic for theory point of view. If not a full question, some note and or this type or that type out of pure tone and impedance audiometry will always be there in the theory exam. And audiograms are always asked in the practical exam, whether it is regular exam, traditional exam, or OSCE or OSCE type. So you must give adequate time to this particular topic, which I feel these days, postgraduates try to ignore this part, which is not a good sign. So I would once again I want to reiterate that this topic must be learned thoroughly by all the postgraduate students. And who is the best teacher for PGs? Our audiometric scientists in the department. So one should interact with them, one should learn from them, and one should thank them for teaching them. Thank you.
Thank you,
so
sir.
much, sir.
Sir, Dr. Aditya Bhargav, sir.
Yeah.
Good evening, sir.
Heartiest congratulations, Ravi, for your excellent presentation. I was there from the very beginning.
Thank you,
This
sir.
has been always a Waterloo for me also. In my postgraduate days and even after my postgraduate days as a young specialist and maybe until date, after retirement also, I cannot boast of that I understand everything about the audiology. There are some many gray areas. So for that, we take your people like you, educated people in audiology, help like you. So my Dr. Pasi has told about that exam point of view, postgraduate residents. But it is not only exam, it is day-to-day practice, because most of us or many of us will go to government services. Now, the question asked earlier was that malingering or non-organic hearing loss. And in medical colleges, in tertiary care hospitals, I have faced this problem in Rohtak mostly, not in Fauj. फौज में तो इतना नहीं होता था ये, because there are no much benefits in फौज. But in Rohtak Medical College, medical legal cases, medical board cases, it is both ways. Somebody wants to gain of hearing loss, somebody wants not to gain from hearing loss. He wants to show that I'm hearing good and my extension of service can be done. Some people want to claim, so many things. So we have to understand what we are ordering. So that now, like I say that it is a pure tone audiogram we have done, but there should be a departmental protocol, not only pure tone audiogram, and it should be authenticated by BERA, SSR, or whatever way. BERA, SSR is also acceptable. Now, what our department had done, not by me, but my predecessors, like Dr. Gulati and all, under this thing of DMER, and of course Haryana government, they had conducted a board in which they have authenticated that these type of cases will have to go to BERA and SSR, have to be authenticated, matched by photon audiometry and all. One more thing, that once we are writing as audiologists, we are writing the report, we must mention that whether these responses are satisfactory or not. That helps us a lot, because if they are not satisfactory, then only we can say that he is having some sort of non-organicities in this. So these are the things which we only learn as postgraduates, and then we can practice in government services, also in so many private practice. When there is somebody wants to gain out of you, he will say that my hearing loss was this, now it has suddenly become I am totally deaf after surgery and all. So these medical legal things and all, you must understand. So that's why audiology is very, very important. Devote full time, as Dr. Pasi has time and again reiterated today, and devote more and more time. Thank you very much. Once again, I congratulate Ravi for a very, very exclusive talk. I have never heard a audiology talk like that in my life before. Thank you very
so
much.
Thank you so much, sir.
Thank you very much, sir, for your valuable inputs. And I would also like to thank my moderators for today's session, Dr. Nitin Gupta and Dr. Nikhil, sir. Thank you for being here, for moderating the session. And lastly, Dr. Ravi, sir, thank you very much. You have completed this vast topic in such a short span of time, and providing all the information about the PT and impedance for the postgraduate point of view. So Now, Dr. Surinder sir and Dr. Upender sir for the final words, then we can end the session. Sir, please unmute yourself, Surinder sir.
I think our senior teachers like Dr. Kwasi and Dr. Bhargav has already said a lot about today's lecture, so I will not go further.
Right.
Dr. Ravi is working with us for the last 25 years or so. We know he's a very capable man. So
But
it was a lecture and it was good for everybody, I think.
I'm asking you because you are the president, so you have to conclude at the end. You're the president of Haryana, not as a professor
People
of
can say
BMC.
I'm biased, so that's why I'm not mentioning. But
Okay.
because even from the same institute, people can say I'm biased, but I'm not.
Okay, sir.
Yes, Dr. Ranga.
There is no doubt about being biased. No, not in this. He has done such a good job, we can't even think of it. So,
Thank you, sir.
the topic, but it has been chosen topic also very thoughtful. It is never done in these type of this thing. So I congratulate all the whosoever has thought about these topics. So this topic is very, very important. There is no doubt about it.
Ranga.
I think it was well conducted and very interactive Zoom meeting on audiology part 1. This audiology helpful to all residents, even practitioner, even institutional fellow. Thank you, Dr. Ravi, for giving such a beautiful talk on audiology, and I think it will help to everybody. And thanks to Dr. Nitin Gupta and Dr. Nikhil Arora. Thank you very much, sir. Dr. Nitin, you always make very interactive talk. Always, last time on the instrument also, you make it very fruitful and interactive. And
Thank you.
And brain behind the show, our coordinator, Dr. Raman Sharma, Assistant Professor, MNC, New Delhi, and Dr. J.C. Pasi, Director Dean, World Medical College, Jajjar. Thank you.
Thank you, sir.
For our president also, Dr. Surinder Singhal, always make constant eagle eye view on the whole of this presentation. And thank you, Dr. Aditya Bhargav, and all the participants who log in today this Zoom meeting. Today we have good attendance of the participants. Thank you very much.
Thank you, sir.
Thanks, sir.
So we can call it a day. So good night, sir. Thank you everyone for joining.
Thank you.
Good night.
Thank you.
Good night.
Everybody.